slide. So your typical history is going to be, it's usually in a competitive athlete, but not always. I have some kids, I treated one kiddo who just did back bends all the time, and then she developed a arch fracture. But it's usually a gradual onset of low back pain. You'll occasionally get the kid that, no, I slid into second base and boom, my back started hurting. But if you question a little bit more, like, you sure you never had any discomfort in your low back before then, or tightness? And then they'll go, oh, well, yeah, occasionally would hurt, or a year ago I had a lot of back pain, but then it got better, and then now it's whatever, but most often it's kind of a gradual onset of back pain, and it hurts with prolonged sitting or standing. They often will get radiating symptoms into the, get buttocks and down the thigh. Oftentimes these kiddos have a high pain threshold. They're, they push. Some of them are doing multiple practices a day. Oftentimes, not oftentimes, I always look for a family history for spondylolisis, because there's definitely a genetic predisposition. So, and maybe that's because anatomy is inherited, right? Go ahead. But I also want to let you know that there is an atypical presentation. And I didn't know this until so Mark used to talk about what he called a lumbar facilitated segment. And what he was talking about was you get dysfunction at a lumbar segment, and you get nerve irritation, it shuts down the glute med, and you've got internal femoral rotation, lateral patellar tracking, et cetera, down the chain. And so things down below can be facilitated by what's going on in the back. And so I was like, sure, that sounds good. But didn't really kind of utilize that until I had this water polo player who came in about 18 years ago, and classic patellofemoral pain. So send him to actually Mark Bowman, probably somebody might know Mark, a good PT, and Mark treated him appropriately, knee strengthening, et cetera, et cetera. After 3 months, I was expecting to send him back to a sport, and he said, I'm better, but I'm still having pain. And so kind of, I just said, okay, and I did his exam, and actually there was no pain on exam that day. And so I just said, let me just look at your spine. And he had an abnormal spine, he had pain with rotation and extension. I scanned him, and so he was hot at, this is the bone spec, this is kind of what we had before MRI came along. So he was hot at left L5, and did a limited CT, and you can see he has actually bilateral complete partial fractures. The right side is chronic, so he had that earlier, and now he's got a complete fracture on the left. Had never ever had back pain. And so I was like, okay, how many of these have I missed? And so I started from that point on, almost everything that walked in my door, I would do a lumbar screen on, and take that into consideration. And if it was abnormal, I definitely get them on the deep core work, and sometimes depending on what it looked like, I might image or whatever. So next one. So these kids are going to present with, most often it's lower extremity pain, so maybe hip, but most often it's hip pain, but some of them come in with thigh pain, anterior knee pain, shin pain, heel pain. Recurrent ankle sprains is another real common presentation. Around that time, I also had a couple of softball pitchers who came in with shoulder and back pain. And I was like, well, that makes sense. They're going to be overthrowing their arm because of they're guarding their knee, et cetera, and their trunk. And so it started, all of my baseball players and swimmers that came in with shoulder stuff or tennis players or elbow stuff. Then I would do a lumbar screen and find fractures. So go ahead, next slide. So then back. There we go. So this was a 13-year-old elite tennis player. I had treated his older brother for a pars fracture actually at S1, and he's playing tennis at Harvard now. And so his younger brother developed an elbow pain. Mom thought I just did spine, so she said, she took him to Children's, and so he went through treatment twice. He went through rehab and then went back to tennis, started having pain again, did the same thing again. So it was about a year period of time there. And finally she brought him in and she said, would you just take a look at his elbow? And he sure enough, he had left tunnel, appendicitis, swollen, et cetera. But because I knew that genetic predisposition, because I treated his older brother, and because now I was aware that sometimes they present differently, so I did a lumbar exam, pain, all ranges of motion, limiting, guarded, and of course Mom was like rolling her eyes, going, oh my gosh, not another one. And so scanned him. We did again, this is before MRI, did a bone spect, and it was just mildly positive at eye level of 5. And bone specs are looking, that looks for increased metabolic activity. So then they'll be positive for about a year, and then they just kind of fade out. So that let me know that, okay, he's early on or he's at the end of this stress fracture. So this is a limited CT, and so again, he's got chronic bilateral fractures at 05. This is the actual view of the, so this view is where you slice them in two and look down on them. So here's the vertebral body, spinous process, and the pars is right there. We did our best to try to get him to heal, but I couldn't get him to heal. He did okay, he got strong enough. He's now playing college teams as well, but had never had low back pain. So actually, around 2018, 2019, Tisha, Jill Erickson, and I, and Terry from Joe's Clinic, Terry's last name, but anyway, went through about 25 years worth of my charts and kind of separated them out to fracture, condition, whatever. And so then Jill and I later pulled all of the fractures, and there were 364, this is just through 2015. And out of 364 fractures, 12% presented with a complaint other than low back pain. And so you can kind of see what those numbers were. Most of them said, if you question them, they would say, yeah, I have a little bit of back pain, but then nothing like my shins or my, Achilles or my knee or whatever. So maybe one day I'll publish this. I've got to go through a lot more charts first, but anyway. So go ahead and go to the next slide. So I'm very acutely aware of people presenting with different complaints that may be driven by the back. So physical exam, this is actually Steve Anderson doing this. It's a perfect picture, so I like to use it, but just a good rotation, lateral bending, rotation, and then extension, one leg extension bilaterally. This is, at least you'll remember this, I don't use this, but a lot of PTs I know do, the torsion test, I think maybe Mark and Ken Cole came up with it, where you push the spinous process while you're pulling up on the ilium, and that can cause pain just because you're stressing the bars. And then I'm going to palpate I'm going to check for mobilization of the thoracic spine. A lot of these kiddos just don't have any motion in those facet joints. So, so on my rotational athletes, oftentimes their fractures are at 3 or 4 because those are more rotational segments. So I'm one of those guys moving in the thoracic spine. Then I just check for pain in the lumbar spine, and then I do that straight leg raise test. I don't know where Mark came up with this, but he would do, and this is how I test, kind of first resistance, where it's straight leg raise with dorsiflexion. And these kids, when they present, you can get them up to about 10 to 15 degrees when they feel a stretch in their calf, and they kind of block out. And I expect that to improve with the multi-leg strengthening. So I'm going to check that every visit. Go ahead and next slide. And so I need to get some imaging to figure out what I'm treating. X-rays most often are not going to be positive unless they've had a chronic bone fracture. Once in a while you're going to lucency, but it's not very common. But I actually did it more for looking for anatomic variations, but they're really neural tube defects, and so that's. Even when I started practice, there was a study already out that said 95% of kids with lumbar stress fractures have either spina bifida occulta or a transitional vertebra. And so I look for those. If I see it, I go, this person's vulnerable. Why? I don't know. I'm not going to be able to answer that question. Maybe somebody doing research can do that someday. But my suspicion is that I think because this multifidi are part of the neural tube, I suspect that when they have a dysfunction in the neural tube development, then I bet the multifidi are shut down or inhibited or something. So I think that because as you'll hear me say later, I found that when kids stop doing the deep core strengthening, that they get weak again and they come back in with back pain again. So well, maybe one day I'll kind of go back through and look at all the kids with spinal difficulty or transitional vertebra sacralization of L5 is most common, or localization of S1. But you got to have a diagnostic study to determine the presence of a stress fracture. That's going to be either a bone spec or an MRI. And nowadays, but the MRI we started using, I guess, about 15 years ago or so. Before there was only bone specs, and you're going to see a lot of these types of bone specs. Children's actually uses bone spec with it's called CT fusion. And so, if the bone spec's positive, then they do a CT through that area. But a lot of times they don't take small enough cuts to get the fracture. And then I've learned that, I see so much other stuff on MRIs, I lean towards an MRI. So,
quick question for you though. Well, first of all, I both have a lumbarized or a sacralized segment.
Okay.
And it's spinal bifida as well, so it kind of fit that criteria perfectly. When you're looking at an athlete and you've taken them through your lumbar scan, what's your criteria? Like, what drives you to go on to imaging?
To get imaging.
Yeah.
You know what? They are either painful or guarded on rotation and extension. It may just be extension.
Yeah.
It's funny. I don't really understand why. There's sometimes where they, like the first visit, they don't have discomfort on rotation, but then the next visit they do. But it's usually painful range of motion. If they don't have painful or guarded range of motion, but they're a little sore on lumbar exam, palpation, like mobilization, then that's not going to push me far enough if they're a little bit sore with mobilization.
Yeah.
But I'm expecting them to have an abnormal range of motion exam. So it's either going to be pain or guarded. And guarded counts because they'll just lock out. You can't extend. I'm like, okay, your back is telling you that if I pull you back further, it's going to hurt. So it's not letting you do that. So I think you're probably right. But that's the main thing. But their neural extensibility will also be really low. And oftentimes they'll actually have weakness, muscle testing or something, hip flexor weakness or hip extension weakness. But that's what I'm looking for.
And then when you're doing that torsion test, maybe we're going to run through that, but.
Yeah, we can go through it. I don't actually do the torsion test. I probably should do it more, but I usually, most of my patients have pain on range of motion stuff. But we can go through that.
Okay, sounds good.
Yeah. So this is just kind of, I don't know if you can see it well enough, but I've got two pictures. This one and this one are pictures of lumbarization of S1. So you can see that there's six lumbar vertebrae, 6 lumbar-like vertebrae, and all of these happen to have spinal bifida occulta as well. So there's spinal bifida, and you see that. So you should have a solid thing right here, and there's kind of a split right in here, and then over here. Yeah. 1, 2, 3, 4, 5, 6. Yeah. So actually, this one has spinal bifida occulta right there as well. So there's just a lumbarization of S1 that's not as common as sacralization of L5. So most of them have sacralization of L5. So that's what this one has there. So I just the radiologists I use now know to call that. So most radiologists will consider that a normal variant, but when I see it, I'm like, you're at risk. And then, of course, on the lateral, I'm going to be looking for lucency. I mean, this kid, you can see, I don't know if you can see it or not, but there's a lucency right here through the cars at L5. And then this one is showing a spondylolysis, so it's got a great slip, so it's putting it up 25% there. I don't typically get obliques, but if I've got a kid that's got a 2-year history of pain, and if they've been resting the whole time, then they're probably not going to show up on a bone scan or an MRI MRI. So I'll may get a oblique X-rays to see if they've got an old fracture. And so this one does. I'm not sure. You're not going to be able to see. I can't see it. So no, actually, there's a lucency right there if you can see it, but that's a good one. Okay, go ahead.
I could dim the lights down too if we're gonna look at more X-rays. What do you think?
You're gonna get. So I think you're gonna be able to see the rest.
Okay,
They're not
sounds
good.
good.
The rest of them are gonna be pretty.
Cool.
Yeah. So as we mentioned before, bone spectration is the only thing we had, and it really is the most sensitive bone study because of looking at increased metabolic activity. So it's the only study you're going to see a stress reaction with. You're not MRI. You will not see a stress reaction on. So what I do now, I don't typically get a bone inspect anymore unless I've got kind of a really high caliber Olympic level kind of athlete that wants to see something, and if their MRI is normal, then I'll do a bone inspect just to show them the stress reaction. But it's still, it's, like I said, they use it in children's and so it does have the background radiation isn't awful. It is there though, and that's why they've moved to MRI, right? So it's equivalent to about 2 years of background radiation. But so I would, kind of as time went on, I stopped doing bone specs on kids younger, that were pre-pubertal. How about that? The concern is more with the body. Although I did one on my 9-year-old son. So it's kind of, you kind of weigh the risk benefits. But now that we've got MRI, I essentially tell patients if the MRI is normal, I'm going to want to treat her as a stress reaction because that's what her exam looks like. And interestingly, as we'll see in a minute, interestingly enough, oftentimes on MRI, I'm finding so much other stuff on MRI now. I'm seeing facet joint effusions, facet joint osteophytes, early DJD, all sorts of stuff that, to me, represent too much motion, abnormal stress. And so I assumed that if I did a bone spec, they would have a stress reaction anyway. So I just treat them as a stress reaction. So, good.
When you talk about neural tube deficits, that's just like an embryologic, like
it is an
developmental
embryologic,
issue?
yeah. A neural tube defect. It's an embryologic development. It's genetic typically. So oftentimes a parent will go, oh yeah, I think I have that. Someone said that, whatever. So and again it makes sense to me that the transitional vertebrae, it changes the spine mechanics, right? I mean, you either got too much motion or you've got not enough motion. So that makes sense as to why you might get a tarsus fracture. But the spina bifida occulta, it's like, just that little defect in the spinous process, how does that play in? So it's the only thing I can come up with. It's an interesting thing, I'll shoot out real quick. I have a 9-year-old, she's a 10 patient that came in with recalcitrant Achilles tendonitis and plantar fasciitis, Q-racer. And so it could, they had been to PT elsewhere, couldn't get it better. And so I sent her over for PT, and so the person I used did some core stuff, but not a lot. And I examined her, interesting, I did a back exam, first visit, and it was normal. So I kind of, okay, we'll just we'll still do some core movies and all that kind of stuff. And now the second visit, she wasn't getting any better, and so I examined her again. Now she's got pain on the MRI exam. So I scan her, I do an MRI, and she actually has at the L3, it's L4-5, facet joint. There's no facet joint on the left side. It's just spicules, bony spicules. So clearly a neural tube defect, just one of those things. So I started her on the multi-body strengthening, and as you'll see, I put them on the elliptical while they're holding that low-level core contraction. And she, after about 2 months, they come in for a monthly visit, and mom says, it's really interesting. She's always been a bedwetter. She would wet the bed every night. And the pediatrician has tried, alarms and whistles and all sorts of stuff, and have not been able to get it better. Since doing the strengthening, she now wets the bed 1 to 2 nights a week. And she's actually gone through, I've been treating her for, it's probably been 1.5 years now, so she'll go through periods where she doesn't do her core work, and she'll get back on it again, and it waxes and wanes with her bed wetting. And so I was like, wow, I haven't had time to look into it a lot, but I did kind of just Google it and found a study that they did did hundreds of bedwetters and did lumbar spine x-rays and found that a third of them had spinal palsy. So there you go. So how about that? It's just, so there's some connection in there. I'm not, I don't know how, maybe the spine has difficulty with the weak multifidi, now that, and you activate the interpelvic fluid, I don't know. Anyway, but there's, so for those of you with pelvic floor stuff, figure it out. But I thought it was interesting. So I keep wanting to ask, I haven't started doing this yet, but I keep thinking, I need to just ask these kids when I find the fracture, were you ever a bedwetter? But it's not, I don't think of it, so I need to try to, maybe I'll get other questionnaires. Anyway, so this is a stress reaction, and I think maybe you can see it. This is mild uptake right here, can you see that? Mm-hmm. Yeah, so this is the L3, but that's what a stress reaction would look like on the bones back, and then you can kind of see it. It's not as clear on the laterals, but here. Go ahead. And then this is a positive bone spec, bilaterally at L5. And you can obviously see those here, the AP view. And here, and he's hot on the left. This is it's a flip image. This is the right side. This is left eye. He's positive on the left, but he's just a lot more positive on the right. And so what I think, go ahead to the next one, and you'll see the lateral. So this lateral. So we're slicing lateral left to right. This is the left side. So pretty hot there, but right side, like really hot. So in my mind, I'm thinking, okay, he's either the left side is older or newer than the right side. Does that kind of make sense? Okay, because it's not got as much uptake and really kind of metabolic activity. So go ahead and go to the next one. And then the axial view, again, he's hot, much hotter on the right side than the left. Now go ahead and go to the next one. Oh golly, well he's down below, sorry about that. I thought I had his picture close, so I'm not good. So anyway, that he ended up having the left side was an older fracture. The right side was his CT. Anyway, so that's what bone specs look like. Now for the MRI, what we're looking at with the MRI, and the reason it's not quite as good of a bone study, but it's getting better, is we're looking for bone damage with an MRI. So you're not really looking at metabolic activity. So we're going to see bone marrow edema, which is just going to be the bone damage. And it really is not sensitive for stress reaction. There are a lot of radiologists out there, however, that if they don't see a fracture line, they're going to call it a stress reaction. But in my world, if there's edema, there's a fracture until proven otherwise. Okay? The other thing, again, as I mentioned, that I can see all this other, I'm seeing all this other stuff, and I've kind of become like, I see a lot of young kids, and as well, more teenagers, but still see many young kids, and those guys, whereas in the radiologist world, and certainly in the adult world, disc bulging is considered normal, but in my opinion, in my world, disc bulging, particularly in a young person, is not a normal finding. And so in my mind, I attribute that to too much motion. Go ahead. So I still need to see the fracture. So what I'm going to do, I want to know how much treatment, if I'm going to be able to get this to heal or not. So I'm going to do a limited CT to see how much of a fracture they have. And you got to do it with tiny cuts, 1 millimeter cuts or so. So go ahead and go to the next one. So this is an MRI and CT. So this is the actual view. This is the left side, the right side. So the left side, she's clearly got bone marrow edema here. And so anything on these T2-weighted MRI views, everything that's white is fluid. That makes sense? Okay. So she's got edema here. On the lateral view, this is the left side, so she's got edema here in the pars, but on the right side, no edema. But then when I get a limited CT, now, so left side, she's definitely got a fracture here. It is not, it's near, I would call that near complete, but she's got an old fracture here. Does that make sense? So she's got, so we try to heal her. She did the right side. So go to the next one. And then this is actually the kid that we saw the bone specked up earlier. So this is more, it's starting to organize more on the left, so it's kind of getting nice and smooth. And but the next step would be the body would just start to cornicate the edges of that fracture, right? But on the right side, he's a mess. He's very irregular, and you go, oh my gosh, that's like that. I know that side's got a better chance of healing. Go ahead. Now, the other thing I would, you know, is that I always have to keep in mind, a lot of people that when they'll see somebody with back pain and they've got a history of, either a history of, or they do an x-ray and say, oh, you've got an old, you know, got spondylolysis or an old fracture. Then they'll say, it's just irritation of that old fracture. But if they've still been playing sport, my experience is they can be developing a fracture. They're just climbing up the chain if they're not treated. So, so with this that's what happened with this kid. I can't remember, I think maybe this is triathlon. And so I did a bone spec, and sure enough, at L4, you see how he's bilaterally at L4 here. And so he's got acute bilateral L4 pars fractures and the chronic bilateral L5 pars fracture. So I don't just stop with, oh, there it is, that's why. You know, I always look. If they're active, I'm going to keep going. Go ahead. This is showing bilateral. So this is that same patient. So this is the chronic fractures at bilateral L5. So here's L5, here's L5 fracture here, and right there. And then now they've got partial fractures here and here at L4. Okay. And you know, they actually don't have to be a competitive athlete. This is a 7-year-old that came in with back pain, very guarded, painful on exam. And I'm like, prison mom, so he's not doing any sports, and he's been doing gymnastics when he's younger, blah, blah, blah. He said, no, the only thing he's ever done is swim lessons once a week. And I finally got to a point where I said, so what does he do in swim lessons? And she said, well, you know, the swim instructor, he's really good at butterfly. And so the swim instructor has him doing a lot of butterfly. And I'm like, oh my gosh. And sure enough, bless his heart, so he does have a lucency on x-ray there. And you can, and this after 6 months of treatment, you know, he is healing. He's got a lot of bridging. I don't know why I don't have it. Oh, I think I was trying to minimize radiation, so I didn't get a CT there, but since I saw the lucency, then I got a CT here. But so you know, you just gotta kind of dig sometimes to get answers. Now, the other thing I want to say is that I have learned that I can't tell the difference on exam between a disc protrusion extrusion or a pars fracture. And I didn't know that until we started doing MRIs. About, gosh, probably 10 years after I was in practice, I actually did for a while I did limited CTs on moderate increased uptake on bone spec. And I would see that many of the pars fractures were associated with a disc protrusion. And so in my mind, I'm like, yeah, disc protrusion is kind of a part of this picture. But it wasn't until we started doing MRIs that I recognized that I was doing an exam and I'm like, yep, I think he's got a pars fracture, and I would do an MRI and there was a disc protrusion or extrusion. And so more of my patients have pars fractures, but they definitely will have disc protrusions or extrusions, and they truly can look exactly the same. The only sometimes they'll smell a little bit more like a disc. You know, if they've got pain, radiating pain down their ankle, then I'm going to go, okay, that sounds like a disc. Or so my pars fractures oftentimes have pain after reflection, but that's sometimes the history leans a little bit more towards a disc. But I tell you, there are times when I'm like, oh wow, I totally wasn't expecting that. And so I treat them the same way because my belief system is that I am now believing that disc protrusions, extrusions, at least in young people, are due to just too much motion. And I almost consider it an overuse surgery because they present with that gradual onset of pain, et cetera, et cetera. Rehab is exactly the same. I do use, for the disc, I do use a soft brace for the proprioceptor to the back, and I do that in pars fractures as well, which I'll tell you in a few minutes. Okay.
Yeah, I can chime in. And that was the case that actually prompted me to reach out to you. Was that this patient of mine had kind of early findings of stress reaction, rehabbed really well, was totally asymptomatic, we hadn't done the like really focused multifidus work, but her exam was awesome. She was progressing very well into heavier loading, and then she went away for a few months, came back with what looked exactly like a disc. And I was like, this is the weirdest thing I've ever seen, you know, like how does this 16-year-old girl have a disc bulge? You know, she's not a 40-year-old, you know, so what's going on here? And that's, we, you know, sent her to you, and she ended up having had taken the fracture that she had, or the early signs of the fracture, and extended it to 2 other sites while she was asymptomatic. So that's where I was like, I was very humbled at that moment.
I mean, it is. It's amazing. It's, you know, it's just, there are times when I'm just like, oh my gosh, you know, how I would never have thought that. But I've seen a disc protrusion in, I've had a 10-year-old, you know, football, doing lots of running, and that's really starting to, you know, he's gotten really slow, he limps, and, you know, says his legs hurt. He was presenting with leg pain, and, you know, it's a disc protrusion, and I mean, it's a 10-year-old. So, yeah, it's interesting.
Too many video games.
So treatment, you know, I have 2 treatment goals. One is to heal the fracture, and I do want to heal. Not everybody believes that. Not everybody thinks it's important to heal the fracture, but I'm a pediatrician by training, and so my MO is I want to make as good of an adult as I can. And I have had I mean, I've been doing this a long time, and I've definitely seen a lot of patients that I have a number of them that don't heal. More of them heal, but there's definitely a number of them that by the time they get to me, it's a done deal. And those people, that they can get strong, you know, deep core and global core, but it's hard for them to get strong enough to do sport at a high level. So what I see is they either continue to have back pain off and on, so they're just kind of doing this wax and waning thing, or they end up compensating and having. So I had a softball pitcher who, by the time she got to me, she already had a great mid slip, and so we got her all strengthened up. She went down to Pomona somewhere and pitched, and she during her 4-year pitching career, she had 2 episodes of a radial stress fracture, just right here, just a radial stress fracture on her pitching arm, just compensating for the power she couldn't get from her truck. And so it's just, so I see interesting things like that. And so my experience is that, you know, the non-union it makes them vulnerable. It is, you know, kind of something that might come back. And then we also, there's studies that show that, you know, within 10 years, my experience is it can be within 1 year, they develop arthritis there, you know, it's wear and tear on them. So that's what I'm going to try to get that fracture healed. And then I'm going to want to strengthen those. I call them deep core muscles just because the kids can't, you know, it's hard, multiply is hard. But in the literature, they're calling them local core muscles or spinal core muscles. And so the way I verbalize it is there's the global core muscles, the guys that wrap around, and then you've got the spinal stabilizers. And I think a lot of the multiply is like the rotator cuff. You know, just they're stabilizers in the spine, and they've got to be strong, just like the rotator cuff does. And so, and I've already told you some of this stuff, but you know, I continue to work on. I mean, it's just I learn something and I change it up, and you know, and I learned from PTs. You know, I've learned a lot from guys that you know, Tisha, Joe, Patsy with Bixby. Some that have seen a lot of my patients over the years. I've worked with you know, Mark and Laura, of course. She split. Although while she was in Belgium, I mean, we kept in touch for I don't know 15 years or so. Just, you know, she would send me bone specs and such, and we'd talk about how to treat them. And she was essentially telling the doctors what to do, which was really kind of fun. And it was cool. But they do heal. And so you'll actually have docs that, and unfortunately there's the head orthopedics at Children's Hospital now. I'm not thrilled about it. I've had people go, ah. But you know, say that, oh, that's not going to heal. No, don't worry about it. Just go back to sport. You know, they're hurting, but they do heal. You know, this person healed and are healing. It takes about a year to heal, so I don't follow them for 6 months. But yeah, go ahead and go to the next slide. So as I was kind of talking about, there have been some people over the years that have kind of done some of the research in the area. Kind of the thought is that, all of the local and the global core muscles, as well as the diaphragm, kind of work together for optimal function. And if you've got a deficit in one or the other, you're going to get dysfunction in the spine. And Hyde's kind of showed the cross-sectional area of the multifidi was reduced on the ipsilateral side of a back injury, and get atrophy, disc or nerve injury. And I love this one, the clear. I don't know how to pronounce that name. But anyway, I like the study. He showed that there was fat infiltration in adults with low back pain. And you can see here, normal multifidi, and then you can see this fat infiltration in people with low back pain. So just, and certainly important, and I think important muscles that we haven't been paying attention to at all. So what I do is after I do it on the first visit. After I see the patient and I go through, this is what I think is going on, I demonstrate, spine model, blah, 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 and talk about imaging, then I teach them how to activate the multifidi. And I go ahead and get it started. And part of what I'm doing is I'm actually marketing is what I'm doing. So what I have them, I've got my hand up under them, and I have them, talk about pulling in the lower ab, and I have them do that, then I have them, so it took me forever, early on in practice, how do I do this with guys, sitting in a bucket of ice water, but then I figured out, stop your P, everybody usually stops their P sub, so that's what I call it, stop your P muscles, and they all know, they all understand that, so activate the inch pelvic floor. There was a time when Mark and a lot of the therapists were doing posterior pelvic floor, but I don't do that. It's what they do is they'll activate their spinae erectors when they pull in the posterior pelvic. I mean, you can do it without activating, but they all did. And so then they would arch, and then they would have pain. So it's like no posterior pelvic floor activation. And then what I'm doing is once I've got them activating the TA, when I do tell them, because they'll all, when they activate the TA, they all will pull in the rectus. And so then I'll do it, have them do it again and say, okay, don't contract this part up here, just focus down here. And so I'll have them do it again, because they don't get better if they pull in the rectus a lot. And then I'll have them contract both at the same time as hard as they can, and then okay, if that's a level 10, let's go down to level 5, and that's okay, now I'm not going to have you do that at level 5 or 10, because it's going to fatigue you about 3 seconds, and it's a waste of time, so we're going to go down to level 2, just barely shouldn't be able to see your tummy move, smallest contraction we can make, and so I get them doing that, and then for years it's usually guys, but it would be some girls, they were either all or none. They could not do just a 2, right? Just a little bit. And so I realized about 3 or 4 years ago that I actually think it on. I don't activate it. I just think about pulling it, turning it on. And I do that all the time when I get that much of a Costco card or whatever, or picking up something heavy. I just think it on, and it works. So I've now started teaching the kids that they can think it on. Because I also think that it's so much, we do lots of outdoor activities, and I do that all the time. I do that stuff, hiking or cross-country skiing or down whatever I do. And so, it occurs to me, gosh, thinking it on during sport is going to be a lot easier than kind of thinking about activating it. So, I've also had probably 7 or 8 kiddos that were either that all or none, and they really liked thinking it on. And I had one kid who had 4 fractures. He actually is going to be playing basketball at Weber State next year, and he went through the whole treatment protocol thinking it on. And I've had a number of others do the same thing. So I know it can work. We have to just be on top of it and make sure they're still activating. But most people like to feel it turn on, and so most people like the 2. But what I will tell them is, okay, I want you to do that. Hold that low level 2. Just turn on your every time you sit down in class. Sit up straight. Activate those. Just barely turn it on. Hold it as long as you can. Forget about it. Just hold it as long as you can. And then I tell them after school, set your phone reminder, go for an hour, and do it every hour.
The thinking it on cue, they actually looked at that. So easier to look at deep neck flexor activation because you can do that through an NG tube.
Yes.
And they've shown that actually you can activate your longus colli and capitis just with the visualization of looking down.
I believe that. Yeah.
So there's some legitimacy to it.
Yeah, I agree. And you can feel the multi-body activate. In fact, oftentimes it's a harder contraction than it is when they're activating it at a tube. So it's interesting. But anyway, so I also, the other thing they've got to know is that they have to be either sitting up straight, standing up straight, or laying flat to activate the cord. So I go through, because as you know, they're all slouching. And so I just kind of say, you cannot, if you're here, those little guys are not going to fully contract. You have to be upright. So once they can, and that's actually why I stick all of my stress fractures early on. I'll eventually put them in a bob, but I put all of them in my disc in a soft brace. I use just the the warm and form brace, and mainly for proprioceptive feedback, just to remind them to get upright and activate their core. It can help with pain some, but it's mainly for proprioceptive feedback because they all self know, and it just is a waste of time. They can't get back up. So when they can hold that low level contraction for 10 minutes, then I'm gonna start on either an elliptical train or an upright bike. And I think I sent that. You got those handouts and stuff I sent.
Yep, I forwarded them to the staff.
So all of the stuff I'm saying is in that stuff. But I'll just what you guys are doing is you are doing all sorts of other stuff. You're teaching them how to ramp, so go from a 2 to 4, 6, 8, back down to 2. So you're getting good core, I'm going to call it core control. Once they have got good core control, and I don't feel the speedy erectors flickering, and you guys feel like they've got really good control, then I'll put them on either an elliptical trainer or an upright bike. And I know that sounds really picky, but I found everything else just doesn't work. It's too much, like Stairmaster's too much. Anything that arches is not going to, or forward flexes is not going to work. But it's walking is actually not enough challenge to strengthen the core enough to get back to sport. But actually, it works just fine for a lot of these moms and these patients. I end up seeing moms and dads, and they're walking, and I'm like, no, just activate your core. I talk about being tall because I have them sometimes pull in the cervical right as well, so just kind of use the string of little balloons, whatever visual you want. But so I'll have them, just activate it while you're walking. But with my athletes, it doesn't keep them strong enough. So I get them on an elliptical or an upright bike. On the upright bike, they've got to be sitting upright. So I have their arms at their side or in their lap while they're spinning. If they're leaning forward, it's not going to work. So they're at lowest resistance, it's like spinning on the elliptical or the bike, and they're activating that core, the core at a really low level. And they start at 10 minutes, 3 days a week, and they increase by 2.5 minutes a week. Until we get, I think I'll send that to you as well, until they get up to at least 30 minutes. 30 minutes is enough for stress reactions and disc protrusions and such, kind of lower level athletes. But I've learned that they have to get up to 40 minutes if they're a higher level athlete to get really good and strong. And then once they're good and strong and they're back in sport, then I take them back out at 3 days a week. And also, either I or the therapist will teach them repetitions, but that is just kind of on and off, on and on and off. Like at a level 5, it's hard to do that at a 2, but like a level 5, I have them do it twice daily. I think it's hard to. It used to be that they would have them do it in class. There was Margaret whoever would have them do it in class, and you can't listen to a teacher and count how many reps you're doing. So I'm like, no, just active. So in class, I have them just low level activation, holding it, and then I say twice a day, do your repetitions, and just kind of like start with like 25 reps twice a day. And that's just on off, and then work up to 50, then 100, then 150, then 200 reps twice a day. So 400 reps a day total. Somebody can go. I know Joe has taken a firefighter through treatment that way before. He actually didn't know it, but he taught the firefighter, he had back stuff to do repetitions. and the guy vanished, and then he eventually came back about a year later, so my back was perfect, and Joe said, what did you do? And he said, I did 100 reps every hour, and it got all better. Well, I don't know any kid that's gonna do that, so I figure if I can get them on the elliptical or like 3 days a week, holding their core for 30 to 40 minutes, that's the best I can do. Go ahead. And then, in addition to though I'm going to tell you that what I just told you is the meat of treatment. That I have folks that I treat across the country by phone. I may see them one time, teach them how to activate their core, and then they're gone. And that's all they do, and they can get better. But if I've got them in my hands, I'm going to have them doing neural stretching, because that makes a difference in the tighter they are neurally, they're going to go into more doses. And honestly, with the multiplier strengthening, I'm going to be able to test that. I'm going to expect them to go from 10 all the way up to at least 60. Gymnasts and dancers and cheerers should get up to 90 without their core activated. As I mentioned before, I want that upper back to be moving well. And so manual therapy, PRI, diaphragmatic breathing, foam rolling. If you guys can't get them better, then I'm gonna send them to chiropractor. And I'm a big fan of corrected foot pronation. Laura wasn't. Laura thought, you can do this with multiply strengthening. And I'm like, yeah, but give them a break. At least get the glutes on a kind of off of that stretch and such. So I do stick them in orthotics. And they're able to drop their pelvis. I do also pay attention to leg length discrepancy because again, a patient taught me that 10 years ago or something when she was almost within the treatment. We could not get her single leg squats for meeting green, to pass kind of green zone criteria. And one leg she was fine, and the other leg she kept going into bow rest. And so finally I said, let me just look at your legs, measure. She was this 1.5 centimeters difference. And so once we stuck a lift in that shoe, boom, she was on it. So I've tested a number of kids that have leg length discrepancy, and they're usually weaker on the shorter leg, but sometimes it's the longer, but it's usually the shorter leg. So if it's at least over 5 millimeters, definitely a centimeter, I'm going to correct that. So I send them over to just to do that. I do use bracing. I'm a pretty big believer. Main reason I'm a believer, not only, there's some good studies that show that there's better healing with putting people in modified posture over that brace. But Lyle McKeely had this great slide with x-rays of a girl out with a pars fracture, bilateral complete pars fracture, lateral view, out of a brace, and the fracture width was in some width, and then in the bob, and the width was definitely narrow. And so that makes sense. If you think about people being in lordosis, it put traction on the fracture, right? And so if you can put them in a bob and get them in a neutral spine, then you decrease the traction on the fracture sheet. So I do put them in a bob, and then if it's a stress reaction or a disc, I'll stick them in a soft brace again for that for complete or near complete fractures, I use electrical bone stem. That definitely makes a difference in healing. So electrical bone stem, definitely it improves bone healing. They've used it for decades, and like scapulae, navicular fractures and that kind of stuff, or fractures that will heal. And then they started using them spine fusions in the elderly, and then we started using them in pars fractures. And I see that it's a significant difference, particularly with the older athletes. So when they're in their growth spurt, they're going to have a better chance of healing than when they're not, right? And so if they're like 16, 17, that definitely, I think they probably heal more because of the bone stem than anything else. So unfortunately, it's not covered by insurance. I use Biomet, and they do. If people can't afford to pay, they decrease the price and that kind of stuff. But anyway,
just to let you know, we're right pushed past 12.
So we're a little bit past
Yeah,
okay.
so we have 5 past, yeah.
Okay, good. So return to play. So usually stress reactions are going to be about 3 to 4 months. Like it's 3 months and then ease them back into sport over 4 months. If they've got pars fractures, it's going to be 5 to 6 months. So they're not going to want to hear that. And there are a lot of people out there, they're like, no, 6 weeks and then you're good to go. And that is not my experience. I have a lot of people that, as I mentioned, come to me from other people that already been treated. And that's just not enough time. It takes about 4 months, particularly with fractures. I think they're just so shut down. It really takes a while to get those multiplied. They're just trying to kind of get back with the program. So they have to, I want their exam normal, and they should be. I kind of know like if they're on the elliptical for 20 minutes, usually their exam is normal by then. So if it's not, I start looking for, okay, what are you doing on the elliptical? Are you leaning forward? Are you looking down at your phone? That doesn't work. They gotta be looking straight ahead. There's all these little, so this is why we're talking about the nuances, it's so hard to, because there are all these nuances to this treatment, gotta be applied. So I look for, so I kind of know where they should be in their, as far as their exam goes, when they're doing their strength training. But once they're holding their core for 30 to 40 minutes, 40 for the higher level athletes, etc., and then doing it, and what I do is the higher level athletes, I'll usually take them under 5 times a week to really get them strong right before I get them back into sport, and then I'll pull them back to 3 times a week and that at 30. And then in your packet, Mark, I guess, came up with the green zone criteria, and those are just tests that they need to be able to hold a 2-minute plank with perfect form using the multiply. A minute's not thing with perfect form, so you can like scroll out perfect form. So those are the tests that you guys do. I want that straight leg raise at 60 degrees, at least at 50, but preferably 60. Fracture healing, I definitely have some kiddos that at 3 months, they're not healing. At that 3 months, I repeat the limited CT at 3 months and 6 months. If they're not healing at 3 months, it's like, let's just get you them strong and get you back out there. So, but if they're healing and if they're wanting to continue to try to heal, then it's usually going to be about 6 months, 5 to 6 months. Then I ease them into their sport. They can't go from no soccer to full soccer. It's all about gradually challenging the course, just like strength training any other muscle group, right? And so if you take them from no soccer to full soccer, they're going to start, the core is going to fatigue and they're going to start hurting again. So I tell them if they have pain on their return, I talk about, if you start feeling tired, fatigued, then you probably need to stop. Or if you start feeling tight, because that tightness is that's quadratus is kind of chipping in. You hear, I'll take over here, or then pain. And those are all signs that I'm pushing you too fast. You need to back down a little bit, go a little slower. Or if you've cut back to 3 times a week, maybe we need to go back up to 5 times a week for a little bit longer. So just but it's all that balance about their core strength and the challenge that they're and this is the other piece. That in my experience is if they don't, I'm sure there are kids that are out there that activating their core becomes second nature. And Mark used to talk about firing core muscle 10,000 times, blah, blah, blah. I don't know how many 10,000 times is, but anyway. But I think there are some kids, I think my son does it, I think he just automatically activates his core. I think there are people out there that can do that, but there's a lot of kiddos out there that if they don't keep up with the core training, they come back and I see them again in 18 months to 2 years with another pars fracture. So it's just, I don't tell them there's an option. I just say, you gotta keep up with the core training. 90 minutes a week is what I tell them. And it can be 330s or 245s, but I think that's what we kind of landed on. If they do less than that, they seem to start having symptoms again. Okay? Yeah, go on to the
How much of the time are you bracing throughout that recovery period?
So I stick them in a soft brace in my office, or within the week, just to kind of get them upright and to give them a little bit of pain relief. The bob, they get it whenever they can, but it's usually within the first month.
Mm-hmm.
And I brace them throughout the whole treatment until they're we're ready to return them to sport, and then I wean them from the bob to the soft brace,
Mm-hmm.
and then have them in the soft brace for a month as they're kind of hardening. And we do a walk jog protocol and all that kind of stuff. And then as I return to sport, and I do kind of a 30 minutes, you know, the first week, increased by 15 minutes a week, with most, like, running sports, soccer, basketball, that kind of stuff. The other sports, we can a little bit different with, you know, what they're doing, but so I keep it, and then I'm like, okay, we know the stop racing except for sport, for, you know, until you've been in there for a couple weeks, and then, yeah, so that's just how I do it. So this is, Dylan Riley, actually, I gotta get a picture of him, he told me, he gave me permission, he's just he's a great spokesperson for this treatment, because he was 15 when he first came to see me. Skyline basketball player, gradual onset of right-sided low back pain, and then 8 months later developed left-sided low back pain. MRI, he had edema, bilateral L5, and we did and you can see a defect on the right side on the MRI, and CT bilateral complete pars fractures at L5 here and here. Treated in the bob, bone stem, core strengthening. 6 months later, he's healing, looking good. So now next picture. So then he eased back into basketball and did well. 6 months later, got busy, stopped doing the elliptical with his core work, and then developed this recalcitrant bilateral quadriceps tendonitis. And he was working his school trainer, sent him to a PT that I didn't know, and I didn't know this was happening. And treated him for 8 months, never got rid of the quad tendonitis, but then he developed more low back pain. Came back in. Now, I did a bone spectrum at that time, and that was positive bilateral at L5. CT revealed bilateral partial fractures here and here at L5. Treated him with bob, bone stem, deep core. Of course, this is when he's doing showcases, right? So we're doing a dance. So he's wearing the bob most of the time, but is you know, taking it off to practice 1 day a week, and then doing the showcases, and he's now playing at Tufts. So doing really good. But that's what I see if they stop doing their work. So if you get questions, no, that's a lot, and there's even more. Yes.
Well, when you're talking about return to play in that timeline, is that typically the timeline you see from when they start to see you, or from their initial onset of symptoms?
No. It's from when they start to see me. Yeah. And you're right. It is. I mean, I've had so many patients that I've patients treated children's and all sorts of places that they are told that no, 6 weeks. 6 weeks in the bob, and then you can go back to sport. You start hurting again, and so I've done it enough that it's just not enough time. They just have to get. I mean, as you know, it takes 3 months to just make a change, functional change from muscle strength, and then they're also trying to heal fractures and such. So, but with the disc, if they're, I kind of use I really use their exam and such infection as a guide. So that's a little bit different than the fractures.
What's the, I'm totally blanking, but the bone electrical stimulation, what's that?
It's just like a muscle stimulant.
Oh, okay.
But it's a lower electrical.
Oh, gotcha.
So they don't feel it.
Yeah, you don't
They put the patches on either side of the fracture side. They have little wires that go to a battery pack. They stick it in a pocket.
Okay.
Or clip it on the bob, and then they wear it 23 hours a day.
Oh, wow.
Yeah. So just like they do the bob.
And are they out of sport that whole time?
Yeah. The vast majority are. Yeah. If they've got, if they're stressed, it kind of depends on what we're doing. I've got a kid right now that he's got bilateral complete fractures, lacrosse and football, and he's had this hiking the Appalachian Trail thing. He's going for 3 weeks. In June is like on his bucket list, and he started in Maine, and I'm like, I gotta do it. He's gonna wear his bob, and we'll see. I don't know if he'll have the most stuff like that, but you just gotta do life. But yeah.
I found that there was a lot of education for parents. Kids were on board, but it was really the parents.
That's exactly
right.
right.
You're like,
Yeah.
kids out of their sport, and it's
Exactly. Well, I tell you what I do. Do we have a few minutes to show who would be willing to be my person that I can show how to show everybody else how to activate your core? I'm going to show you what I do. test them
Yeah.
the first visit. So this is what I was saying I was marking. So what I do is I teach them how to activate their multiply, and then I test gluten and without the core and with the core, and then I test supraspinatus. Two muscles I can always look at the supraspinatus, right?
Mhm.
So, but they're strong, when they activate their core. So the kids are going, oh, how does that work? And the parents are seeing. So I truly, that's one of the main reasons I do it. So because I'm marketing that treatment, is what I'm doing.
Yeah,
So,
you're selling it.
Yeah.
Lindsay's been working on her core.
All right. Very good.
Been a little busy.
Good deal.
We need a table?
Yeah, table. Yeah.
Oh, that's my great.
And the main reason, I know you guys know all this stuff, but I have to be honest, but I remember when I did a in-service at when they took over to ATI. You guys know Chad Williams, remember Chad? Chad Williams, he was at Olympic with Mark
Okay.
for a while, and then he stayed on with ATI. And I did an in-service, and so Chad was my victim, and I was like, no, take it down a little bit lower. He was like, you're kidding, it's that low? And so then I realized, no,
Yeah.
I gotta, so yeah. So
It's definitely the hardest thing, right? Like as a
Yeah.
patient, I was a PT,
Yeah.
and it was the most frustrating part of the whole process. It was like
Yeah.
trying to find this muscle, and Laura's like, no, not that. I'm
Yeah.
like, I don't know.
I
Like,
know, right?
yeah,
Right.
so I think there's a lot of coaching and like empathy building with the patient
Yes,
during
yeah.
that phase.
Exactly. So I put the arms down on your side. And then I always, most people that I know do this. I know there's one PT I know that does it like this, but I don't know how they do it with big guys. But anyway, so go ahead and relax on my hand. So I just get my, I'm using my thumb and forefinger on either side of the spinous process. And so, okay. Lindsay, okay, good. And just go ahead and relax those. There you go. So I'm just gonna say, okay, so just barely pull in, or just early on, I'll just say, just pull in the muscle below your belly button. So pull that in. Good job. And that's right. Yeah. And then I'll say, okay, now don't pull in here, just pull in down here. Do that again. Good job. And relax. That's okay. Now the other, what I'm saying is, in order those multifidi are really deep, so it's hard to go right to them and fire them up. So we have to do it a roundabout way. So one way we do it is by having you pull in this muscle, and then the other way we do it is there's some muscles deep in your pelvis you can pull up a little bit. So it's the same muscles you use when you stop your pee. So try just using your stop your pee muscles. Good job. And relax. Good. So and I can feel her activate when she does both of those. So now what I want you to do is both of those at the same time as hard as you can, Lindsay. So pull in your lower ab and use your stop your pee muscle as hard as you can. Good job. And relax. Perfect. So that's a 10, as hard as you can do it. Now do it half that hard at a 5. Good. And relax. Perfect. So we're not going to do it at a 5 or a 10 because it's going to fatigue in about 3 seconds and then it's a waste of time. So we're going to do it just barely, like at a 2. And it is so subtle, I shouldn't even see your tummy move. It's the softest contraction you can make. So try to just very barely pull in your lower ab and use your stop your pee muscle and turn it off and on and off and on and off. Good, you're doing good. Let me give you a couple more pointers. These big guys, they're speedy erectors, want to get with the program, but you have to make them relax. So make these guys just sink into the table. So most of them, I'd say half of them are kind of up a little bit, so I'm getting them down. and then I'll also say, so a lot of people like to try to coordinate their breathing with the contraction, but I don't want you to do that. You keep breathing, but we're just gonna do this down here, okay? Do it separate. So now try again, just softest contraction you can make. Barely turn it on and off and on and off. And on and off. That is perfect. You got it. Good. So now, try just thinking about it. So then I'll say, now you can actually think about that contraction and it works. So try this time, just think about pulling in and up. So try thinking it on and off. Good. And on and off. good. And on, and off, good. So if that's a 1, then barely turning it on is a 2. Although it's actually backwards. I mean, you're that strong. That is stronger than the 2 is, which is okay. But I want the 2 that low. So now, totally relax again, and then again, just barely turn it on and off. Perfect. And on and off. Perfect. And off. Perfect. You got it. And so then I'm going to tell them. So now I'm going to test it. So I'm going to just do that. And I've already done that neural extensibility test earlier. But so pull your foot back as far as you can, and I'm going to lift your leg, and you tell me when you feel a stretch in your calf. Okay. Good. Now barely turn your core on. And say when. Okay. Good job. Turn it off. Barely pull this foot back for me, and tell me when you're stretching this. Good. Now this time think it on. And good job.
Yeah.
You guys can all tell. She can go about 10 degrees higher,
That's
which is
great.
what I expect. And that's what, if she doesn't, then she's not doing it correctly. The other thing I can tell is if she's pulling in her spinator erectors, her hand, she'll fight me with her hamstring. So those are just some things I can learn. And then I'll have you roll over on your side and face the wall, and straighten out your legs. And so then I'll talk to him about the glute med being weak. Lift up and roll in. No core. Don't let me push down. Hold me up. Okay. Sorry. And now, and I'll kind of cue them a little bit. Barely turn your core on. Good. And don't let me push down. Hold me up. Good job. And relax. And then I'll have you swing around. I'll actually do it on the other side, but we won't do that today. Swing around and sit up. Press your angle. So, this is when I'll say, in order to activate your core, you either have to be laying flat, sitting up straight, or standing straight. Because I'll sit up and stop. So sit up straight for me. Arms up to here. Thumbs down. Come forward. Let me put your arm right here. No core. Don't let me push down. Hold me up. Good. Okay. That's okay. Now, barely turn your core on. And don't let me push down. Hold me up. Good job. And relax. Perfect. Good. So they're going, wow, how does that work? And the parents are seeing what's happening. And so I just kind of say, you're going to be stronger all over by the time we finish, working with you. So everything. If they're an upper extremity person, at some point in time, I'll actually have them pull in the cervical core, like on the elliptical. So on the elliptical, I have them do a kind of reset or check-in every 5 minutes. Every 5 minutes, keep the elliptical going or the bike going, and just turn your core off and back on again, and make sure it's not on too hard and and is on. So I'll have them do that reset kind of every 5 minutes. But what I'll also do, eventually I'll pull in their cervical core, and I'll just kind of say, okay, look, why don't you pretend like you've got a string from here to the ceiling, so just kind of sit, let it like pull you up, or little balloons. One of the therapists came up with little balloons. I love that one. Or just little balloons that are lifting you up, or just being tall. And so then I'll test them again. So don't use here, just use your string is what I call it. So don't let me push down. Good. Okay, now use your string and activate your core. You got it? And don't let me push down. And see, that's stronger than both of them separate, right? So it also amplifies. So if they're not getting as strong as I think they should be, probably because they're not holding the core the whole time, on the electrical, then I'll pull in their cervical core and have them do that. So, make sense? Cool. You guys want to feel? Do you mind if people?
That's fine.
Feel kind of how that low level contraction. Yeah, that would be great. And then, or I'm glad to do it on you. I do not care, whatever you would like. So if you want to, you might want.